Hello, everybody. Today I'm going to talk about listening for Parkinson's disease and dystonia. And we are all thankful to our teacher, Professor Thaira from Tokyo Women's University, Japan. And before we go into listening topic, I would like to tell you that, functional neurosurgery to come up to this level, we have been doing, smaller things, smaller steps and a slow learning curve we had. Like we started with the microvascular decompression for trigeminal neuralgia, hemifacial spasm, glossopharyngeal neuralgia, 2000, almost 20 years back. Then we started doing epilepsy surgery 2 years later, and we are doing a lot of epilepsy surgery these days. Then we started doing selective neurectomy and selective dorsal rhizotomy in spasticity patients in 2005. And then we started from 2006 doing listening, and from 2014 DBS. So it's a gradual learning curve. Now we are ready to start psychosurgery in our institute. So this is, when we actually started doing listening, we were doing this with a CT based and ear encephalography, sort of, very old technique. And we didn't have RF listening, so we are using a monopolar. We tested on eggs to see that we were doing a 3 millimeter sized lesion. And this was our first case, was a patient teacher with a tremor and hand dystonia, and we did it in an awake situation. And but then we realized that we need a better equipment. Although this patient and a few others did well, but then we thought that we need a better equipment to restart this technique. And so if you look at the history of pallidotomy listening, then it was introduced in 1946, long time back, and then it disappeared, reappeared, disappeared many times. Like once the levodopa was started, then it almost disappeared. And then, once the ventrolateral targets was found to be better, then it was restarted. And then once DBS came up, then it was completely abolished in many places. But then with focal ultrasound listening, it has again reappeared. So, basically with DBS or listening, you are just, deep brain stimulation is actually a misnomer. Deep brain stimulation, you are not stimulating that part of the brain, but you are actually suppressing that part of the brain. So it is you are doing the same thing by doing listening or by DBS. The only big benefit is that with time the disease progress, and then you can control the parameters. So that is the biggest advantage. So our method is that we either take 1.5 or 3 Tesla without any spacing MRI, volumetric MRI, and you need to see the STN and GPI. Visual seeing is also important, and we use ZD Fisher frame. And once we put the frame, then we do a CT scan, and then we fuse the CT scan and MRI, and then we determine the ACPC line and then calculate from there. And we have 2 targets for GPI. One is the primary target, like this, and then we have a secondary target which is 2 millimeter lateral and 3 millimeter posterior to the primary target, and we make lesion in the both targets. And as you know that ACPC line has got a different size on different peoples, and this has to be considered. And so Nepalese population is 24.9 according to Sambardhan et al. So we calculate on our population basis. And so once we have done targeting on the MRI, then we reconfirm that on Saltenburn atlas on the axial and coronal image. Both targets are seen, and we want to go as close to the internal capsule as possible. And then we put the patient's frame into a Mayfield head holder, and then we do a phantom simulation outside to see that our target is correct, and then we do a C-arm verification to see that our target is in the center of the moon. And if it's a DBS, then we always do a microelectrode recording, and depending on case by case on GPI, we sometimes do microelectrode recording, but not always. Using microelectrode recording give you more information, but then it will slightly increase the possibility of bleeding, intracranial hemorrhage. And all of the surgery we do on awake surgery, and then we do a neuromonitoring all the time. So like this is the operative setup where the patient is being tested for hand movement, and she is saying words, and then we ask for the visual, because GPI is very close to the optic tract, so they may have flashes. So if you see that, then you have to come a little bit above that. And we use RF generator, and this is Costman, and we first do a test stimulation, high frequency test stimulation, just like a DBS, and for up to 3 microvolt, and see that if there's a dystonic posturing or visual problems or speech problem. And then we do a test lesioning to see that we are still not damaging anything. So this is a reversible sort of lesion. And then if nothing happens, then we make a permanent lesion by 75 degrees Celsius, 16 seconds. And our probe is 0.75 millimeter, internal diameter, exposed tip is 2 millimeter, and we presume that the lesion is made of 2 millimeter size. And this is already a lesion is made in this MRI, and that's the lesion. So, once we target very near to the optic tract, then we make the deepest lesion first, 2 deepest lesion, move 1.5 millimeter each time, and then we go to the target, and then another 2 lesions above that, and we do the same on the secondary target. So total of 6 millimeter size lesion is made, a total of 5 lesions. And we have 60 cases of movement disorder from this 6 years period. 15 were there of dystonia, 7 bilateral, and 7 were stage unilateral. So equally we do 1 time bilateral and stage unilateral equally. And task-specific focal dystonia, we only have 1 case, and this essential tumor 3 cases. And in Parkinson's disease, we have got 19 cases of DVS, mostly STN, but there are 2 cases of GPI and 22 cases of GPI lesioning. And so this is, once we make the lesion, like this is a bilateral GPI lesioning, we re-verify that we have reached the target by fusing the pre or post-op image, and to see that we have made the right track, followed the right track. And these are some of the lesions, like unilateral lesion right above the optic tract, and then bilateral lesion. One is bigger than the other. So depending on laterality of the symptom, we make one side bigger and one side smaller. And the result of Parkinson's disease, we have got 41 cases, and 19 cases of DBS, 22 cases of lesioning. Both groups have, everything looks similar, and the UPDR score is also same on both lesioning and DBS. So if you look at this chart of UPDRS score, then the improvement is seen in both lesioning and DBS. Actually, in lesioning, the improvement is slightly better in our cases, which is not statistically significant. So both is okay for us. And out of these comparison charts, most of the things are similar. Only thing is surgical time is much less with lesioning, 1.5 hours. And the most important cost factor is $2,000 and $20,000. So there's a big difference here. And decreasing the level of dopaminergic doses, only we can do 10% decrease in listening cases, whereas 30% in DBS. And complication rate, if you look here, the complication rate is much less in listening, whereas we had one case of ICH hemorrhage, one hardware complications, one suicide case which could be related with DBS, which is reported in many literature. And another thing is you don't need frequent follow-up in listening. Once you do it, you are done with it. Some of the case of Parkinson's disease with listening, this gentleman is very stiff and has difficulty walking, and then now you can see that he is much better with bilateral pallidotomy, staged bilateral pallidotomy. This is a patient with dyskinesia, very severe dyskinesia, and then so in one case of Parkinson's disease, the tumor was so severe, and then it didn't go away just by GPI, so we also added VIM in the same sitting. So sometimes we re-innovate depending on case. On dystonia cases, there were 15 cases, 9 bilateral pallidotomy at one time and 4 unilateral pallidotomies. And there was no DBS in dystonia cases. Everything looks similar, and there is no comparison between DBS because we have not done any DBS in dystonia cases, and there is 90% improvement in FNDRS score in our series. And there is a recurrent in 2 cases of dystonia where we had to do repeated surgery, and there is no mortality in any of our series. So this is a case of a severe dystonia, one stage bilateral in a young man who was walking like this for the last 7 years. And immediately after surgery, he is much better. And this is generalized dystonia, mainly neck and arm, moving towards the right side. And then this is immediately after surgery. You can see that his dystonia has been much improved. And this is another cervical dystonia where we did a bilateral one-stage GPI listening. This patient was looking toward the sky for the last 10 years. He could not, walk facing straight, and then post-operatively he was immediately better, and then for the first time after 10 years he was looking straight. And this is a case of musical dystonia. He's a professional drummer, and he has got a stiffness of his hand and he cannot move his hand properly. And we did this surgery while he is playing madal, and he could go back to his professional life. He is one of the very famous drummer from our country. So in this case, we did a VOA thalamotomy, and that's the lesion. We made 2 targets. And for essential tumor, we do thalamotomy, and the patient is cured on the table like this. And these are some of the failed cases, like this lady who has got a central dystonia and very severe deviation of the mouth, and she cannot open her face. And after that, she can open her face and her mouth became better. But then immediately after that, she became similar, and then we had to do again another surgery, and then again she became better, and then we did a bilateral again. So we had to do 3 times, and every time this patient recurred. Every time she get better with GPI listening. So now I think we only have the option of STN DBS in this lady. So our thought process is that mixed syndrome which is mixed syndrome, which is oromandibular dystonia, and other central dystonia, they have bad prognosis outcome. So while looking at our pre-post-op, then we realized that when we are doing GPI, we were actually doing some listening of the STN also when our angle of the approach was 40 degree. And as you can see, in the same plane, you are going to the GPI and also to the STN. So in the future, we are going to do a prospective study of this. and whether that will improve their outcome or not. So our present thought process is that we want to do for idiopathic generalized dystonia, young patients less than 45, we want to do a bilateral pallidotomy. If there's a tumor, it's a VIM, VIM thalamotomy. Young onset Parkinson's disease, dopamine-induced dyskinesia, DVS is better option, but if they are not affordable, then you can do a bilateral pallidotomy. And marked on-off, wearing off, and age is less than 16, ST and DBS is an option. For task-specific focal dystonia, we advise BOA thalamotomy. So in conclusion, unilateral or stage bilateral pallidotomy is safer than one stage, bilateral pallidotomy. However, we prefer bilateral pallidotomies in dystonia cases with one lesion smaller than the other one. And for PD pallidotomy, in our cases, it has surpassed the number of DBS in our setup because of cost effectiveness and do not require time consuming adjustment, and there is no hardware related complication. But then the problem is that you cannot adjust with time if the disease progresses. But with this experience, we think that listening is going to stay with time, and probably it is going to again become more and more common. Thank you very much for your attention.